stay at the top of yours. You strive for perfection. Aspire to the gold standard. Spare no effort. You give it everything. We're constantly improving and innovating to remain at the top of our game. Now, introducing the Ligoshaw Exact Dissector, helping you to stay at the top of yours. The jaws have a low temperature profile and are designed to help reduce thermal spread to surrounding critical structures, while the rapid jaw cool-down time of the device enables secure and atraumatic grasping of tissue. Your success relies on exact precision. So we created a slim, tapered curved jaw, giving you optimum line of sight for precise, blunt dissection, even in the tightest of spaces. Your best performance relies on control and balance. So our intuitive design naturally supports use in either hand, offering precise control through its ideally optimized length. We all aim to be the best. Improved control and efficiency minimize procedural interruptions in the OR. Lead through performance with the Ligoshaw Exact Dissector. Together, we can achieve a great performance.
The head and neck surgeries you perform are vital. Your patients place their trust in you. You help them continue to speak and smile, eat and drink, hear and comfort. You're committed to helping them continue to live fully, to feel deeply, and to enjoy the quality of life they've come to expect. That means being confident that you're protecting and preserving your patient's head and neck nerve function during procedures. Introducing NIM Vital, the next generation of nerve monitoring technology. NIM Vital provides advanced nerve monitoring that helps you reduce the risk of nerve damage during head and neck procedures. Detailed intraoperative nerve condition information helps inspire your surgical strategy. An intuitive user interface with a wire-free patient interface allows for easy setup and enhanced visualization from the surgical field. Real-time notifications of nerve conditions, visually and audibly. Green, yellow, and red status bars provide visual information, and their associated tones provide audible cues, making monitoring function easier than ever. NIM Nerve Trend EMG reporting enables nerve condition tracking throughout a procedure, even when using intermittent nerve monitoring. And when paired with a NIM continuous monitoring electrode, you have continuous nerve monitoring informing your surgical strategy. NIM Vital pushes the boundaries of monitoring nerve function in various procedures in head and neck surgery, with real-time information available during surgery, giving you confidence in nerve function. Because protecting patients' nerves and senses is more than vital. NIM Vital.
Great. Mr. Ram?
Yeah, I can.
You mind?
Do a correction.
Yeah.
Okay. Welcome back, delegates, and hope you're still with us and having the energy to be with us, and hope you're enjoying all these lectures. So we go on to the last part of the section. Our next speaker is Professor Kim Ahsee. He is a very experienced consultant head and neck surgeon working at Aberdeen Royal Infirmary, Scotland. He is the examiner and also the external advisor for the Intercollegiate Board of Examinations in Otolaryngology in UK. He's also the NHS Director of Undergraduate Medical Education. He is also the educational and research convener for the Scottish Otolaryngology Society. He will now be talking to us on the role of PET in head and neck. Over to you, Prof.
Thank you, and welcome to this talk on the role of PET-CT scanning in head and neck cancer. My name is Professor Kim Ahsee. I'm a consultant ENT head and neck surgeon in Aberdeen Royal Infirmary, and I'm definitely not a radiologist, so this talk will be very much from the perspective of a head and neck surgeon. A little bit of background first. I thought it'd be interesting to look at the timeline for PET-CT in head and neck. And this is a relatively new technology developed in the early 90s by Nutt and Townsend when they were working together in the University of Pittsburgh, and it was there that they developed the first PET-CT prototype, with the first commercial system reaching the market by 2001. In my local hospital in 2006, March of that year was the year that we scanned our first patient in our hospital. And over the subsequent years, clinical indications for PET-CT scanning in all cancers has changed and followed the evidence. And in 2014, in Scotland, head and neck cancer became one of the accepted indications for the use. So what is PET-CT scanning? Well, it's a whole body scanner. It's three-dimensional. It's functional in nature, using this radioactive tracer that we can see here being introduced into the patient's arm. It demonstrates metabolic activity in the cells to do with glucose metabolism, and when fused with a CT image, can give us some really nice, colorful pictures, as you can see here. One of the things that I've learned is that its resolution is limited, and lesions that are less than 1 centimeter in size tend to be below. In Scotland, the activity of PET-CT is predominantly through lung cancer patients, but head and neck cancer, as you can see here, is certainly a small but growing area of development for the use of these scans. Now, in Scotland at least, and this is mirrored across the UK, in November of last year, the Scottish Clinical Imaging Network came up with these indications for when we should use PET-CT in the management of head and neck cancer. And I'm going to touch on 4 of these that are highlighted here. Firstly, patients with proven biopsy-proven metastatic cervical lymphadenopathy with no primary found, so the unknown primary. Secondly, and an area that I think many of us in head and neck are used to dealing with, is assessing the response to treatment 3 to 6 months following, so for example, chemoradiotherapy. In patients with clinically suspected recurrent disease post-treatment, so sometime down the line there may be the suspicion of recurrence, and conventional imaging results are either negative or equivocal. And finally, staging of advanced disease in the head and neck, especially with N3, or advanced primary disease in the hypopharynx and nasopharynx, since these will have a high incidence of distant metastases for which PET-CT may be helpful. So cancer with the unknown primary, Here's some examples from the literature. This is a 57-year-old man who presents with metastatic lymphadenopathy, and we can see on conventional imaging here there's a large lymph node. Similarly, on this patient over here, there's a lymph node mass to be visible here, but it's perhaps not immediately clear on these cuts as to where the primary source might be. If we then add in PET-CT, we can see how the base of tongue in this case and similarly base of tongue in this second case highlight. So it's giving us that direction that we need to identify. So how good is PET-CT in identifying unknown primary? Well, these cases occur in perhaps up to 7 or 8% of head and neck cases, and it may well be that PET can help identify the site before we proceed with panendoscopy. In the meta-analysis of 16 studies performed by Rusthoven, it was found that PET-CT detected an additional 25% of primary tumours in the 302 patients studied. In addition, it was helpful in identifying unsuspected regional or distant disease in 27% of these patients, giving it an overall sensitivity and specificity of 88% and 75% respectively. And these figures were reproduced by Zhu et al. In a large study of 246 patients with a sensitivity of 97% for detecting the unknown primary, and not unsurprisingly, the commonest. The second area that we're perhaps familiar with using PET-CT, certainly in our practice, is in the post-treatment surveillance. So here are two examples, the pre-treatment scans at the top and the post-treatment scans at the bottom. This is a three-month scan after chemoradiotherapy for a left base of tongue tumour with significantly enlarged left-sided lymphadenopathy, in this case similar but with bilateral involved lymph nodes. If we then look 3 months down the line, we can see response to the treatment with loss of FDG uptake here, and similarly complete response. So how good is it? Well, PET-CT in a study by Ong of 65 patients had a sensitivity of 71 and 89%, but importantly, I think in this clinical setting, had a high negative predictive value of 97%. So a negative scan is very good at ruling out the presence of residual disease. And this finding was confirmed in a large meta-analysis by Gupta et al. Looking at over 2,300 scans in 51 studies, again confirming a very high negative predictive value of 95%. And of course, many of us will be aware of the large prospective randomized controlled trial of 564 patients, both HPV and HPV unrelated disease with advanced neck nodal disease, the so-called PET-NEC study. And this, the result of this study showed that PET-CT surveillance was not inferior to planned neck dissection, since many patients were saved the added morbidity of a neck dissection. This was Mahan et al. In the New England Journal of Medicine in 2016. One question perhaps is, when is the best time to perform the PET-CT in the post-treatment phase? And two meta-analyses have helped us with this, and they've concluded that imaging with PET-CT should be done no sooner than 12 weeks after completion of definitive treatment. And we can imagine that this is to allow the resolution of any post-treatment. And when it comes to detecting recurrent disease, both local, regional, and distant, PET-CT similarly has a benefit here. This is a case, for example, with a right tonsil tumor, which has responded very well to treatment in the post-treatment scan, but at this stage is when distant metastasis in the lung has been detected. Similarly, patients who have responded well to the treatment, but at subsequent scanning have found, in this case, to have a retropharyngeal lymph node, and in this case, to have distant metastases in inguinal So how good is it at detecting recurrent disease? And Sheikh Baha'i and his colleagues identified in a large meta-analysis that the sensitivity and specificity of PET for detecting recurrence was 92 and 87% respectively. Pretty good figures. And this sensitivity and specificity was maintained at further down the line at 4 to 12 months at 95% and 78%. Similarly, Goa et al. In a meta-analysis of 10 studies looking at 797 scans identified a sensitivity of 92 and a specificity of 95% for screening for distant metastases in patients who had failed their treatment or had evidence of recurrence and were on the verge of undergoing salvage treatment. So as one can imagine, detecting distant metastases would have an impact. And this brings us back to the question again about timing and the surveillance of these patients after treatment. And this is a really nice study produced just last year by Resor et al., showing how over time the negative predictive value is high. We know that from previous studies, and it's high from a very early stage at 3 months. But what's encouraging is also that the positive predictive value improves over time as well, such that at 6 months we have really good negative and positive predictive values, and this is studying 270. So I think what we can say is that head and neck patients with a negative 3-month PET scan probably have little additional benefit from subsequent scans, and Goel et al. Concluded that the best clinical approach was to perform a PET CT maybe 4 to 6 months after definitive treatment, and if this is negative, then that obviates the need for any further studies, unless obviously there's some clinical suspicion of disease recurrence. When it comes to managing advanced stage disease, then PET CT can have a significant impact on the management of these cases, and 2 studies have demonstrated that. Lono et al. Identified that PET CT was altering the management of 14% of their cases, and similarly, Chekikedo et al. Identified that 26% of cases had their management changed in the initial staging of these advanced diseases, largely because of the presence of distant disease, such as in this scan here in Kaelin Rath's paper revealing liver metastases. So this is clearly going to change your management. I'm aware as a non-radiologist that there are some limitations for PET, and as I've mentioned already, if the lesion is less than 1 centimeter, this is considered below the spatial resolution of PET CT. We're also aware that there are false positives because PET scanning is really measuring the glucose metabolism of tissue, and it's not cancer specific, so benign disease, infections, especially TB, and also some physiological activity can highlight itself on PET CT. And similarly, incidental findings, because this is a whole body CT image, we may find unexpected findings such as intrapulmonary nodules that will need to be monitored. It should also be said that other malignancy of a non-squamous type, such as, for example, adenoid cystic or some thyroid cancers, are not particularly PET avid, and therefore we need to be aware of that when looking at. So here's some examples of limitations. Here's some physiological uptake in the parotid glands and in the submandibular glands, and also some physiological evidence here of compensatory movement of the right vocal cord in a case of idiopathic left vocal cord paralysis. So there's no cancer in these scans, and yet there's quite avid uptake that's visible here. Similarly, post-treatment, you might see some avid uptake here, but this is a case of laryngeal cartilage necrosis following radiotherapy. And as mentioned already, TB is very avid on PET CT. So this upper scan here shows a very avid tuberculous disease in the upper lobe, but treated very successfully with antimicrobials such as this disease disappears. Here's a case of my own, a 67-year-old male who's 9 months following chemoradiotherapy for T3 supraglottic. Despite his treatment, he had ongoing pain, hoarseness, and difficulty with swallowing with the aspiration and an unsafe swallow. And conventional imaging was equivocal, and despite multiple examinations under anaesthetic and several biopsies, we were unable to definitively identify any residual disease. And at this stage, a PET-CT scan was performed, and this revealed this very avid hotspot here in the side of the larynx, which was reported as suspicious of recurrent disease. We discussed this with a patient who, in essence, had a dysfunctional larynx, and there was this high suspicion of recurrent disease, and he underwent a salvage laryngectomy. The pathology confirmed fungal infection with no evidence of cancer. And unfortunately, as in some salvage cases, he did not do well, and his wound healing was poor. And I'm afraid this is a picture of his wound breakdown with a large fistula between the neck and the larynx. I am pleased to say, however, that this responded well to reconstruction with a pectoralis major flap. But this highlighted, to me at least, the importance of being circumspect when looking at the positive results of PET-CT and considering the possibility of other disease. So in conclusion, I think it's fair to say that PET-CT scanning can help us with the identification of the unknown primary. It's very helpful in staging and planning for advanced head neck squamous cell cancer, with the impact that it can change our management decision in a significant number of cases. It's helpful in the initial post-treatment response, but we should be aware that this should not be sooner than 12 weeks post-treatment, and can be anything up to 6 months post-treatment, as we know that the negative predictive value is maintained at a very high level up to that stage. Surveillance protocols really at this stage are not clear. It's not part of our routine practice beyond the post-treatment scan, and there's perhaps more research to be done to identify what sort of protocols would be beneficial. And finally, I think, as just mentioned, we should all be aware of the incidental findings and the false positives that can be detected with PET-CT scanning. So that's all I have for you at the moment, and I'm very happy to take questions. Thank you.
Thank you, Kim, for that wonderful talk. I know the transmission was a little bit problem with that, but otherwise the slides and I was able to hear everything that you said, and the slides were flowing very nicely, and all the points were very clear. Thank you for that. There's one question, Prof. The question is from Mr. Ahmad. The question is, we are at times met with patients who have base of tongue and lingual tonsils hypertrophy or asymmetry, where MRI scan is non-conclusive. Would a PET-CT be considered as an alternative to EUA biopsy, especially if the patient is at high risk for GA?
That's a very good question, and is a challenging scenario. I think we have to be aware, however, that a PET-CT will show some physiological uptake in the lymphoid tissue in place of tongue, and we will really be reliant on our clinical assessment of the patient's base of tongue. If possible, in clinic, palpation as well as infection would be helpful. I think if you're really keen to get a biopsy of this area, then perhaps you might consider topical anesthesia and a biopsy with a channeled scope in the clinic, especially if the risks are very high for anesthesia. But in that situation, you would have a frank discussion with the patient along with the anaesthetist giving the anesthetic, and we would come to some sort of agreement as to the pros and cons of proceeding with a biopsy. So that's not it's not a yes or no answer, I'm afraid, but that's how life is, and we will have to navigate all the pros and cons. We don't typically do PET-CT for asymmetric lingual tonsils. That would be not seen as one of the indications for using this sort of modality. I think we may stop at MRI and then chat with the patient, maybe try local anaesthetic biopsies in the clinic if feasible, and then have a chat with the anaesthetist. Just how quickly we could take a biopsy, perhaps even with some sedation, that might help to take a biopsy without having to resort to a full general anaesthetic. I hope that helps.
I think that's the only question I can see, Kim. Yeah, thank you for that lecture. Thank you very much for that. And thank you for your time as well.
You're welcome.
So we will, Jay, are we okay to move on to the next lecture, Jay?
Yes, please. Yeah.
Okay, so our next speaker is Dr. Dympna Mcteer. She's a very experienced consultant radiologist working at Aberdeen Royal Infirmary, Aberdeen, and we are very fortunate to have her. She is one of the lead radiologists and runs the Head and Neck MDT. She also is very active in postgraduate teaching and training, and we have bi-weekly radiology sessions, and she has a wealth of information and we learn a lot from her. And she will be now talking to us on imaging for thyroid disorders. Over to you, Dympna. Thank you.
Hello and welcome to the Scottish ENT Radiology course. My name is Dympna Mcteer. I'm a radiologist in Aberdeen, and today I'm going to speak to you briefly about radiology of the thyroid, predominantly looking at ultrasound in the evaluation and further management of thyroid nodules. I would strongly recommend these two documents to you. One is from 2014 from the British Thyroid Association, with a very comprehensive overview on the management of thyroid cancer. And a more recent document from NHS Scotland is a consensus guidance on a variety of areas within management of thyroid cancer, from the physicians, surgeons, radiologists and pathologists' point of view, looking at items that we all find difficult in current practice. A little bit of background, the incidence of papillary thyroid cancer has tripled over the last 30 to 40 years, and yet the mortality remains stable, as does the autopsy rate of detection. So this increase in thyroid cancer is largely due to the incredibly high rate of detection of papillary microcarcinomas by modern imaging. And most cases of papillary thyroid cancer are now diagnosed based on an incidental finding rather than a patient presenting with symptoms. This has led to incredible overdiagnosis and overtreatment of this condition, which is very much in contradiction to the principles of realistic medicine. Our aim would be to really diagnose only clinically significant disease, and as we know, many of these small papillary cancers never materialize into clinically significant disease. So we're keen to avoid overcall of these incidental thyroid nodules on cross-sectional imaging, and when we do turn to ultrasound to help with characterization. On ultrasound, there are several features which are helpful to us in determining whether a thyroid nodule is indeed cancerous or benign and can be safely ignored. These are some of the features that we use to assess a thyroid nodule. As you can see, microcalcification, irregular margins, and a hypoechoic echogenicity are quite important. Microcalcification, when present, is highly specific, but it's not found in in all thyroid cancers. Irregular margins, again, quite specific. If a nodule has very irregular margins, that's highly suspicious. And also hypoechoic nodules have a much higher risk of being malignant. Presence of a halo and intranodular Doppler signals are not as helpful, as you can see from the sensitivity and specificity. There are a number of classification systems when looking at the ultrasound of thyroid nodules, and the one we use locally is the British Thyroid Association U classification. And you can see that this classification ranges from 1 to 5, with U1 indicating a normal thyroid gland, U2 a benign nodule, U3 an indeterminate nodule, and U4 suspicious, with U5 being an overtly malignant lesion. I'm going to show you some examples of these nodules now, just starting with U1, where we have a normal thyroid. This is the right lobe of the thyroid. This is the trachea, and lateral to this we've got the carotid artery, and the jugular vein will be here compressed by the probe. We've got the infrahyoid strap muscles over the thyroid, and also the sternomastoid muscle anteriorly. U2 nodules have a number of features, but this is a typical what we call spongiform nodule, and we can be quite confident on ultrasound that these nodules are benign. They have a very distinctive, as I've mentioned, spongiform appearance. See the trachea in the background, and again the carotid to the left and the jugular vein, sorry, to the right. U3, unfortunately, these are provide a large number of nodules that we see, and particularly in a patient with a multinodular goiter, where the nodules are solid. Sometimes they have a little bit of a hypoechoic component, sometimes they're slightly irregular, so really not enough features to make them overtly malignant, but not enough features to consider them U2 and dismissed. So this is quite difficult in terms of ultrasound characterization. U4 nodules are those where there is relatively high suspicion, but appearances are not overtly malignant. And this is showing you a nodule within the right lobe of the normal background thyroid. It's well defined. There are no evidence of microcalcification components within it. However, it is quite distinctively hypoechoic and solid. So hypoechoic echogenicity is a feature that is quite concerning, and therefore this would require further investigation. U5 nodules, we mentioned overtly malignant nodules, and this nodule has all the features of malignancy, being incredibly irregular, having lots of microcalcification, and being generally hypoechoic. In these cases, you may find that there is associated cystic lymphadenopathy, which is further evidence of malignant disease. I'm just going to show you a CT image. We tend to reserve CT for the staging of high-risk cancers. Ultrasound is much better at characterizing both the thyroid primary lesion and the presence of lymph nodes. However, for high-risk tumors, we use CT both for surgical planning and looking for distant metastasis. This CT image is showing you an irregular tumor within the right lobe of the thyroid. You can see that it's breached the capsule and is extended out laterally, and that there are some large supraclavicular metastatic cystic lymph nodes. CT, as mentioned, is also useful in the detection of distant metastases, and this CT image is showing you a lytic metastatic deposit in the right iliac blade. MRI we tend not to use a lot in the initial diagnosis of thyroid disease. However, it is one of the imaging modalities where incidental findings include the detection of papillary thyroid, either primary lesions or indeed lymphadenopathy. And this is an image from a patient who was having an MRI of her cervical spine when these two lymph nodes, one right level 5 and one right level 2, were detected. They are not particularly large, however, they do have cystic components, and this is what raised the suspicion of a metastatic thyroid cancer. Extensive investigation of her thyroid gland proved difficult to identify a primary tumour, but ultimately fine needle aspirate of these nodules confirmed the diagnosis, and she proceeded to thyroid surgery and neck dissection. PET scanning does contribute considerably to the number of thyroid nodules requiring further investigation, and while these are often incidental, they have a 1 in 3 chance of being malignant. Quite important to consider the reason the patient was having a PET, as sometimes it is for the staging of a cancer that is more likely to influence the patient's lifespan than an incidental thyroid cancer. Remember also that in the treatment of thyroid cancer we use radioiodine. This can also be used as a diagnostic tool identifying the extent of metastatic disease. Currently we use a considerable amount of SPECT scanning, where we have a CT image combined with the radioiodine scan, which helps in locating the anatomical site of the thyroid disease. So, in summary, there's been an exponential rise in imaging, and this has led to an escalation in the detection of incidental thyroid nodules, which are very common in the population. This has led to overdiagnosis and overtreatment of thyroid cancer, as many of these small nodules would never progress. We can reduce the number of patients proceeding to surgery by using ultrasound to dismiss those nodules which are evidently benign. We can also dismiss some of the nodules by using ultrasound guided fine needle aspirate. But having said that, there is a considerable need for the application of principles of realistic medicine, and I'm going to finish by reminding you of those. Thank you very much.
Thank you, Dympna. That was a wonderful lecture, very crystal clear, and for a non-head and neck surgeon, I could understand very nicely. Thank you for that. What I'll do is, if you don't mind, can you check at the chat question and answer section? If there's any questions, please can you answer them, so that I will mute myself so that there is less feedback. Okay, I will pass it over to you, Dympna.
Yes, there's a question. I'll just read it out for you. Is there a role of ultrasound core biopsy of the thyroid gland with repeated Thy1, or how to deal with repeated Thy1 cytology? Probably would be better for a cytologist to answer that, but our local experience is that we have very skilled cytologists. So generally, the diagnosis is made after 1 or 2 FNA attempts, but we have done on occasion, we have done a core biopsy. Sometimes it's helpful, sometimes it doesn't add to the diagnosis. So it really depends on your cytologist, but locally we don't often do core biopsies, but we have the facility to do that.
Brilliant. So maybe I can ask one question. Dympna, do you think the thyroid ultrasound should be done by specialist radiologist?
I would love to offload some of my thyroid ultrasound. So no, not at all. Actually, at the moment we have a maxillofacial surgeon training in neck ultrasound. He's doing a formal course in neck ultrasound. For him, he wouldn't normally deal with thyroid at all. But by the end of his training program, he will be more than confident in assessing thyroid nodules. So I would very much encourage my surgical colleagues to take on targeted neck ultrasound scanning. Absolutely. Even I know, even for targeting an FNA, etc. But you know, the demand in radiology greatly exceeds our capacity, and it's being escalating. So perhaps maybe I should be asking you to be more rigorous in your clinical assessment rather than doing ultrasound. Maybe these people shouldn't be having ultrasound at all. So perhaps I would request that the surgeons make a more rigorous clinical assessment. You know, traditionally we dealt with palpable lumps with patients presenting with a new lump, and now all we're dealing with is incidental small lesions that have been picked up on imaging as an incidental finding. So I think if we're going to try and curb the overdiagnosis, overtreatment, I would be asking for a more clinical decision making.
And there's one more question for you, I think. Or two more.
Okay. Two more. Okay. Contrast enhanced CT or MRI better option for thyroid malignancy planning for radioactive iodine? If so, after how long? That's an interesting question. We used to be quite concerned about doing CT with iodine-based contrast medium because of the impact on subsequent radioiodine treatment, because obviously the iodine-based contrast floods the thyroid, and therefore the uptake of radioiodine would be limited. I don't know if it's a good or a bad thing, but locally, by the time they're getting radioiodine, the CT scan has long since passed. So our local clinicians are not concerned. But if you're working in a centre where your radioiodine was very efficient and it came very quickly after your surgery, then that might be something to consider. We used to say 3 months, so really you should try and avoid your radioiodine for 3 months after iodine-based contrast. I suppose if you were going to be doing your radioiodine quite quickly after the CT, then I would suggest a non-contrast CT, not ideal, limited anatomical detail. So I probably would suggest MRI as an alternative for the surgical planning side of things. Remember though, you'd probably need a plain CT if you were looking for lung metastasis. So you might have to consider MRI and CT chest. But it depends really the timing of when your radioactive iodine is going to be. So we would say 3 months. So locally that's not an issue, but in some centres it might be. I've got another question. Is it a formal course with the Royal College? I think that might be in reference to ultrasound. And this is, it's a bit of a novel experience. My surgical colleague is doing this through Caledonian University in Glasgow. And it's really courses designed for sonographers, but this is a specific neck ultrasound course. So I think he's the first clinician to do this course, and they're modifying it accordingly. It's very kind of designed for sonographers, but I think after he goes through, he'll have some feedback ideas as to how, you know, you approach it as a clinician. So I think as a clinician, maybe less physics, and but it's going to be good. It's going to be good. I think it's important for him because while he's quite skilled in ultrasound, I think he's going to have a formal certificate of training and assessment. And I would recommend that for anyone contemplating doing neck ultrasound, because we all miss things. But it's defensible if you have evidence of formal training and assessment, whereas if you're just dabbling in ultrasound, it's hard to defend if there's any discrepancies. But I would encourage you to consider it and, you know, investigate where you can access a course.
Brilliant. I think that's all done. Thank you. Mr. Ram, do you want to introduce the next?
Okay. Jay, are they here, or is it okay? We are going to do it just a recorded thing.
Yes.
Okay.
They will be joining. Yeah.
They will be joining. Okay.
Good.
So we're coming to the last topic of our conference today. We have 3 consultants who will be joining from Glasgow. These are pediatric consultants, pediatric ENT surgeon, and one pediatric radiologist. They all work at the Tertiary Center, Royal Hospital of Children in Glasgow, which is the fantastic center with loads of cases on pediatric issues, and it's a great center for training. And they in fact cover and provide excellent service for across Scotland. It's the regional center for managing all the complex pediatric cases. So we have 3 consultants. One is Kerry McAllister and Tash Kunandam. Both are consultant pediatric ENT surgeons. And then we are very fortunate to have Greg Irwin, who is the consultant pediatric radiologist. So they will be talking to us on the topic pediatric ENT imaging. Over to you, Jay.
I'm Kerry McAllister, one of the pediatric ENT consultants at the Children's Hospital, and I'm going to talk to you today about congenital ear deformities. I'm just going to bring your slides up. So we're going to have an overview of ear deformities, look at which imaging can be used, and we're going to discuss 2 clinical cases. So congenital ear deformities are fairly common in 1 in 10,000 to 1 in 15,000 births, and they can be